Good afternoon, and thank you for joining us for this special program, California's Master Plan for Aging, What Does Health Have to Do with Housing? My name is Tim Kawahara, and I am the Executive Director of the UCLA Ziman Center for Real Estate. Today's symposium is jointly presented by the UCLA Ziman Center for Real Estate's Housing as Healthcare Initiative and Levine Program in Housing and Social Responsibility. Part of the Ziman Center's mission is to educate and serve the public by presenting timely topics of interest related to real estate through a multidisciplinary lens. We draw upon the rich intellectual capital across the UCLA campus, notably including the UCLA Fielding School for Public Health. Today's symposium will discuss California's Master Plan for Aging, which was released this past January and will specifically try to answer the question, what does health have to do with housing for the older adult population? And present a thoughtful discussion on how this blueprint for state and local government, the private sector, and philanthropy can prepare the state for the coming demographic changes in the over 60 segment of the population. We have put together a prodigious group of experts on aging, health, and housing fields, and we sincerely thank all of them for their time and for being with us today. If you received the earliest announcement for this symposium, you would have noticed that one of the panelists was Dr. Steve Wallace from the UCLA Fielding School of Public Health. And unfortunately, Dr. Wallace suddenly passed away in March. We would like to take a brief moment to recognize Dr. Wallace and the profound impact he made in the field of public health. He was a husband, father, brother, friend, and for those of us at UCLA, a wonderful colleague. When we dreamt up the concept for a housing as healthcare initiative at the Ziman Center, we knew we needed some friends and colleagues at the Fielding School. And when these crazy people from the business school called Dr. Wallace with our ideas, he graciously listened and welcomed the opportunity to engage with us. And for that, we are eternally grateful. Among other roles at Fielding School, Dr. Wallace served as the Associate Director of the UCLA Center for Health Policy Research. He was an internationally renowned scholar on health disparities, health policy of older adults, immigrants, and other marginalized groups. That Dr. Wallace, whose career in public health spanned 40 years, chose to focus much of his efforts on improving the lives of the most vulnerable members of our society, speaks volumes about his character and his sense of decency. And COVID-19 has only laid bare and exacerbated the social inequities in healthcare. And we are grateful for scholars and researchers like Dr. Wallace, who was an early pioneer in addressing these disparities in real terms. On campus, Dr. Wallace was a passionate educator, mentor to countless students, researchers, and colleagues who will carry on his work. If you are inclined to learn more about Dr. Wallace's remarkable career and accomplishments, I believe we have posted a link to his background in the chat. With regard to this particular symposium, let me just mention that Dr. Wallace developed the California Elder Economic Security Standard Index, a tool that measures the actual cost of basic necessities for older adults, which was adopted into law, State Assembly Bill 138, and was used by the World Health Organization in its 2020 Decade of Healthy Aging report, and will also be used in the California's Master Plan on Aging. While we will miss Dr. Wallace's presence today and to the contributions he would have made to the conversation, let us use this symposium to celebrate his life. Let's be grateful for the innumerable lives he improved through his work. Let's be grateful for the time we did have with him, that we had the opportunity to witness his kindness and compassion firsthand, and for the impactful body of research he leaves behind. Perhaps most significantly, let's be grateful for the many students, mentees, and researchers that he trained and inspired, and who will carry on his greatest professional aspirations. I can think of no more profound or meaningful legacy that anyone could leave. So Steve, to you, we dedicate this symposium. Now let me introduce my colleague, Christina Green, Program Manager of our Housing as Healthcare Initiative. She is responsible for organizing much of today's program, for all of the success we have had achieved to date, and for cultivating and stewarding strategic partnerships in order to advance human health and well-being. Christina.
Thanks so much, Tim. And hello, everyone. I am Christina Green. I'm thrilled to welcome you all to this year's joint Housing as Healthcare and Levine Symposium. Thank you so much for being here today to share this time with us. One housekeeping reminder, we will have time to take questions from the audience following the panel discussion, so please don't hesitate to post any questions in the Q&A box at the bottom of your screen. You will also have the opportunity to upvote other people's questions by clicking on the thumbs up icon. I also wanted to especially thank my Ziman Center colleague, Julie Lindner, who is the program manager of the Levine Program in Housing and Social Responsibility, for collaborating with me on today's event. As Tim mentioned, the Ziman Center launched the Housing as Healthcare initiative in 2018 in an effort to raise awareness about the various challenges and opportunities that lie at the intersection of housing and healthcare. Civic engagement and public service are fundamental to our mission as a public university, and service in the form of educational programming is key to carrying out this mission. In the last year or so, I've been engaged in a partnership with a fantastic working group exploring a housing-based scalable system for California that would empower older adults and vulnerable populations to live and age well in their communities and homes through a connected network of services. What we're calling the California Integrated Care at Home is a systems change approach, which is built on best practices from proven housing-based service models like Vermont's Support and Services at Home. It is a coordinated, more participatory approach that links healthcare and where people live. We'll hear more about this later in the program. But the Ziman Center's work in this space has led to our interest in learning more about California's Master Plan for Aging, where housing and health policy meet, as well as the experiences and perspectives of current housing and health partnerships in the senior nonprofit affordable housing world. These are the overall topics that we plan to cover in what we hope will be an engaging and educational symposium for all. Today, we are so appreciative of and grateful to these community leaders and industry experts who are joining us to have this conversation today. Our keynote speaker is Kim McCoy-Wade, who is Director of California's Master Plan for Aging. The panelists are Sarah Steenhausen, Director of Policy and Advocacy for the SCAN Foundation, Christina Serrato, who's Director of Operations of Episcopal Communities and Services Affordable Housing Portfolio, and Doug Shoemaker, who is President of Mercy Housing California. I'm excited to introduce you to our moderator for today's discussion. Megan Rose is General Counsel and Director of Social Impact Initiatives and Housing Policy for Leading Age California. In addition to serving as in-house legal counsel for the organization, Megan's chief responsibilities include advocating in the state legislature and working with regulatory agencies to help expand affordable and service-enriched housing to California's most vulnerable seniors. Megan holds a bachelor's degree in politics and economics from the University of San Francisco and a JD from the Santa Clara University School of Law. Not only has Megan been a true joy to work with and become a friend of the Ziman Centers, but her strength and dedication to serving the complex needs of the older adult population is tremendous. Megan, we thank you, and the forum is yours.
Thank you. You make me blush. My name is Megan Rose, and I'm the General Counsel and Director of Social Impact Initiatives and Housing Policy for Leading Age California. I really want to thank Christina and Tim and all of your Ziman Center colleagues for putting on today's program, and what a program it is going to be. Leading Age California represents over 500 nonprofit providers of senior housing, care, and services across the aging continuum. So one thing I constantly hear from affordable housing operators is that their residents are aging. 20 years ago when their community opened, the average age of their residents was around 65, and now it's closer to 80. This can present challenges for housing providers who have few staff and often little training on meeting the needs of their aging residents. And these residents are the lucky ones. They're the ones who were able to get an affordable unit. Across our state, affordable senior housing communities are seeing waitlists 3, 5, sometimes 10 years long. A permanently housed senior in Los Angeles once told me, "I thought I would die before I got off the wait list and into a unit." In Oakland, hundreds of older adults camped outside overnight for a chance just to get on a wait list for an affordable senior housing community. There simply isn't enough senior housing in California to meet the demand of our aging population. Because of this, we're seeing older adults becoming the fastest growing demographic within our homeless population. So what are we doing about it? Is the state building more affordable housing? Yes-ish. With the recent government preferences for building larger family, apartments, and workforce housing, seniors have a hard time finding affordable housing that meets their needs. So today, we're not going to focus strictly on our housing supply issue. We're all very familiar with that. But we are going to talk about the housing needs of our older adults. older adults have special housing needs. Let me say that again. Older adults have special housing needs. The older we get, the more likely we are to have mobility issues, to have one or more chronic conditions, and to need help with activities of daily living, such as cooking and self-care. And what better place to address the well-being of our older adults than at home? Housers, you often know your residents better than anyone. Your service coordinators, your maintenance staff, they notice if Mrs. Smith hasn't come out of her apartment for a couple days or if Mr. Jones is seeming agitated lately. So today we're going to talk about what it's like to be an older adult in California. We're going to learn about California's long-term care continuum and some of its challenges. We're going to talk about what housers can do to help their residents age in place, to help reduce housing exits and improve health and quality of life. We're going to hear from housers about their successes and challenges in creating and running health and housing models. And we're going to talk about California integrated care at home that Christina mentioned earlier. And all of this is going to be presented in the broad context of California's new master plan for aging, a progressive plan which has listed housing as its #1 priority. And who better to introduce us to California's master plan for aging than the state's biggest advocate for our older adults. Kim McCoy-Wade is the director of the California Department of Aging. She most recently served at the California Department of Social Services as the CalFresh and Nutrition Branch Chief, where she led the expansion of CalFresh food benefits to older adults and people with disabilities, as well as several data and technology initiatives, including the Get CalFresh mobile app. She previously served as a consultant to multiple health and human services nonprofits and as executive director of the California Association of Food Banks. Earlier in her career, she worked in Washington, D.C. for the Children's Defense Fund, Bread for the World, and Alliance for Justice. She is an alumna of NYU School of Law, Carleton College, and the Jesuit Volunteer Corps. Please join me in welcoming Director McCoy-Wade, who will provide our opening keynote.
Thank you so much, and good morning to all. I am honored and humbled to be here, hopefully as a living legacy of Professor Steve Wallace's work. This presentation, I would say, is in tribute to him, but in fact, the entire master plan is a reflection of his legacy. And so you will hear me refer to his work and how we have really strived to live up to the high standard he has set for all of us in person-centered, data-driven, rigor, and equity focus in California's master plan for aging. So with that, I will kick off and you will see, I hope, that we have done justice to his amazing life and legacy here. So yes, California has a master plan for aging, and I will quickly tell you how, why, where, when, what, and what it means for housing, really. And you'll quickly see it. I want a spoiler alert, but housing is the very first bold goal, and it is woven throughout. And let me tell you why and how we can work together to achieve this goal. Next slide. So in the very beginning, 2019, can you think back to pre-COVID? The governor had the vision to know that California was not ready for what's happening with our population, that more of us are living longer, bonus years, aging is changing, and it's changing California. And so the governor called on the full cabinet to do a master plan for aging, more than housing, more than health. All of our family life, community life, our businesses will be changed by what's happening with aging. Let me tell you a couple quick facts. Next slide. With the governor's executive order, we dove into the numbers and said, yep, Californians are living longer than ever before. Before COVID, it was close to 82 years. Of course, great disparities among gender and race and ethnicity, but nonetheless, one of the longest life expectancies in the country in California. And while we will have experienced with COVID some significant reduction in life expectancy, particularly among Black elders, Latino elders, and some Pacific Island elders, we are very hopeful that with California's coming back and with this master plan, we will not only regain those lost years, but close the equity gap in living longer. So number one, we're living longer. Number two, next slide, please. More people will be older than younger. So this slide, the most important thing to see is if you look at the dark blue, light blue, orange bar on the left, you see we have more people under 18 than over 60 in 2010. But by 2030, the balance shifts, it swings. And there are more of us over 60. And this has profound implications for our families, for the kind of housing we want, for our communities, for our workplaces, for the services we need, And it also has a real implication for how do we make sure public services like, say, for example, a park work well for the 8-year-olds and the 80-year-olds? How do our community centers and our schools serve all ages and in fact bring ages together? And how does housing work for multi-generational, all ages populations? And then the third slide about how aging is changing is diversifying. California's older adult population is the only population that is still majority white, but over time will be diversifying to reflect California's terrific tapestry of different races, ethnicities, and cultures. And so we will have a more diverse aging population. And you know what? Different cultures have different ideas about aging, different thoughts about living alone in a home, may have different feelings about multi-generational housing or nursing homes or residential living. And the fact of the matter may have more housing equity, housing assets. In fact, we know that in order to afford the bonus years of living longer. So aging is changing. So with those facts, we got to work, and the governor's executive order empowering all of us, we got to work on a master plan for aging. Next slide. We kicked off in the summer of 2019. We thought we were busy then, had lots of public participation, a stakeholder committee of over about 100, including Professor Steve Wallace on our presenting at one of our very first meetings, the research subcommittee on the Elder Economic Sufficiency Index, and really providing the profound insight that what is driving affording aging are housing costs and health costs. So that actually older adults in LA were really struggling to be economic secure because of housing, because of housing costs, yes. And then, but Humboldt County, they were struggling just as much because of healthcare costs. So if you don't look at housing and health, you really aren't going to get there. And that was Professor Wallace's insight, which really deeply informed us. We also had legislators have roundtables all over the state. The governor with First Lady Maria Shriver convened a task force on Alzheimer's. And as I mentioned, we had the whole cabinet, not just housing and health, veterans affairs, food and agriculture, thinking about older farm workers and the importance of nutrition, corrections, aging prisoners, all were at the table. And so we were really looking at what does it mean to have an aging lens on what we do? And because of this process, we had more than 800 recommendations come in from our stakeholders, thousands of letters and comments. But I have to acknowledge that in March 2020, everything changed with COVID really hitting our community. Next slide. So two things that we say gave us, 2020 vision last year. One, right before COVID hit, our stakeholders had said, if we don't bake equity into this process, if we just sprinkle it on top, it will not truly build a California for all ages. We need to make sure that achieving equity is in our values. We also need to have a special equity work group that is laser focused on disparities in aging and legacy of a lifetime of discrimination. We created an equity tool. The stakeholders created an equity tool with 6 questions on equity that we wanted to put all of our proposals through as a ringer to make sure they were advancing equity and not moving us back. You'll see it baked in our bold goals, again, reflecting Professor Wallace's work, and our over 100 initiatives we assigned ourselves as a cabinet for the first 2 years, and our metrics. Again, we want to measure not just how is California doing, but how are all of Californians doing across age, across race, and also LGBTQ, ability, language, and many other important indicators. And then, of course, COVID accelerator. Beginning in March, COVID just shone the harshest of spotlights on what we knew about the inequities and getting healthcare, lifetimes of healthcare, and weathering the economic storm that was COVID. People were asked to stay home. Well, staying home takes support, whether it's a family caregiver, whether it is meals being home delivered, whether it's a friendly person to talk with you so that physical isolation doesn't become social isolation. All of these were strained, and even more so for people who did not have internet and were not able to get telehealth or attend to worship services or chat with family members if they didn't have that digital connection. And unfortunately, we saw and continue to see ageism that, both kind of stereotypes older adults and even in benign ways can kind of dispose of older adults. As we all know, older adults were about 80% of the deaths and about 40% were in nursing homes, one of our primary housing options. And so we really need to take a harsh look at how ageism is getting in the way of us making progress on a California for all ages. And throughout both of these issues, we really tried to take the equity and the COVID and bring it into the master plan, which we were thrilled to be able to release the first week of January this year with 5 bold goals for 2030. And I'm going to talk briefly about these goals and how they relate to housing. So next slide, please. Here are 5 bold goals that we've heard from Californians we engaged with. We need housing for all ages and stages. I'm going to talk about this in a minute. I think California has a legacy of talking about housing for older adults in a certain way, and we want to broaden that and reinvigorate that as we go all in on housing in California. 2, health reimagined. Health, of course, is so much more than what happens in your doctor's office. And as you age, health happens at home and in the community. And how can we support health at home? 3, inclusion of older adults, equity for older adults, not isolation. Older adults and all ages of the lifespan are part of a full life, a full family, a full community. 4, caregiving that works. We have a real challenge. Family caregivers have both the joy and the sometimes burden and stress of caring. That's the primary caregivers of older adults. And we also have a real shortage in direct care workers who did just heroes work. I would be remiss if I didn't acknowledge the governor's proclaimed today a day of tribute and recognition for our nursing home workforce. I want to thank them for their frontline service. And then goal 5, where Steve Wallace was so influential, affording aging. We have learned that older years can be a year of downward mobility. And the primary drivers of that are not just the erosion of private pensions, of private saving and Social Security barely keeping up, but also those rising costs of housing and health that Steve taught us about and demonstrated about with his data so profoundly. Okay, so let's dive into housing for a second. What does it mean, goal 1, housing for all ages and stages? What we heard from, next slide, please. What we heard from Californians all across the state is we all want to live where we choose as we age. I hope as housers this resonates with you. In communities that are age-friendly, disability-friendly, and dementia-friendly, and climate and disaster ready. So the target here is millions of new housing options. I'm just going to pause here for a second and say a moment about this. I said earlier, California has done a lot in 2 places, at 2 ends of the housing spectrum, I would say. For homeowners, we all know Prop 13. We're going to help you keep that home that you bought in the 70s and 80s affordable as you age, okay? And then we have nursing homes at the other end of the continuum, the most intensive, expensive level of care for people who have that serious level of health needs. But you know what? People want a lot more in the middle. Even those folks who are out there and have a home, whether it's ownership or a renter home, they need help with home modifications. They need help with preventing homelessness. You know that over 50 is the fastest growing group of homeless folks, first-time homeless, because they can't afford that rental payment. So we need to prevent the homeless, keep them in the home, modify the home, surround them with home care workers, home delivered meals. That's one model. And that's the most expensive model there is, right? But that is a model that a lot of people like. Here's the second model. More and more people want to live with their family of choice. That could be multifamily housing, multi-generational housing. It could be ADUs. Lots of folks think ADUs, and San Diego's leading the way, are such great potential. Why? Stay in your main house, put an ADU in, you could have a younger relative live there. You could have income generation there. You could have a caregiver live there who otherwise couldn't afford to live in that neighborhood. Flip it, make the ADU totally accessible and one level. You live out there and you can rent out that front house to a younger family member, again, rental income or a caregiver family. Or the multifamily housing. People want to live together, avoid that isolation, help each other with meals, help each other with transportation, and those kinds of family, we need to think more creatively about that. Third on the continuum, what we used to call senior housing, but this is that community housing we're going to hear more about in a minute. We need to build so much more of this, so much more affordable, and merge it with that services. Is there a care coordinator? Is there a nurse? Is there someone on site who can help provide that health and social support and, you know, broadband, all the things to make that housing great? And I have to say, I'd love to see intergenerational opportunities in there. Can former foster youth, can college students, can people live there? And I know there's stereotypes about that, but we've got to figure that out so we don't isolate the ages. The fourth is our licensed residential care. This is a huge area, both the small 6 beds and the larger institutions. Those are increasingly an option for people, but they remain unaffordable for many people. How can we have Medicaid and Medicare help people live in that type of licensed housing model with support if they want to and need to? And then last but not least, how do we keep nursing homes the right size? That they're there if you need that level of care, but we're not People aren't sliding there because they didn't have the option at 2, 3, and 4 that they would have preferred if they could have afforded it, if it was in the community they loved. So that's why I'm here. And so I hope you're going to take the challenge, is that we need more on all of those places, accessible for us as our abilities change, affordable for us as our income declines as we age. And of course, housing's not an island. You need housing with transportation. Older adults increasingly get out of their cars, a wonderful power for our green economy, but we need to make sure we're not stranding them in these homes. Outdoors and community spaces, emergency preparedness as wildfire season started last week. And of course, again, climate-friendly aging. We can't be assuming everyone is in a single-family home with a car and save our planet. So how do we as aging and have more choices to drive both living at home and community and a green planet? So I spent a minute on housing because I wanted to do that, but here's the interesting thing I hope you'll see. Housing didn't just show up in goal 1. Briefly, if you look at goal 2, next slide, health reimagined, we are really trying to make those healthcare dollars appropriately pay for home. If Medicaid's going to pay for the nursing home, wouldn't Medicaid be better off paying for home delivered meals and a home modification and a family caregiver respite? And I could go on, but those are the kind of things, and I'll even say it, a rental payment that could help a person stay in a home and have the independence and quality of life and avoid that costly nursing home experience if it's not what they need. So you'll see our health agenda has a lot of housing pieces. And again, nursing home, we really like to move from the large institutional settings to smaller. There's so much opportunity for housing developers to help us figure out how we build small homes, pods of 6 people living around a shared living space, much better for quality of life, much better for worker engagement, much better for infection control. How can we just like seismic retrofitting, how can we do small house retrofitting to make nursing homes a better home environment? I could go on, but I will go quickly to next goal 3 about inclusion and equity. Similarly, we want housing. We don't want senior housing off on the side. We don't want senior centers off on the side. We want community centers, community housing, community parks. How do we bring the ages together? We love that our governor's commitment to broadband for all singles out both kids at the Department of Education and older adults at the Department of Aging. Everyone's got to get online to be connected as much as possible with the right device, the right broadband, and support to learn and help and have content that means to you. It's more than just a laptop, we all know. And last but not least, this is where goal 5, affording aging, you'll see Steve's work again. The affording aging is specifically linked to his research. We will have economic security for as long as we live, and our target is with his metric that he developed to close the equity gap among races and genders and increase economic sufficiency for all. We can do it, and it's Steve's data that's allowing us to measure it and hold ourselves accountable in a rigorous, person-centered, equitable way. And this is the ultimate tribute to Steve, is that he's changing things in California because of his work here. And we're just so grateful to have his expertise, his wisdom, and again, even doubling down more on meeting this goal in his honor. And this in particular, one of our strategies, we have to end homelessness for older adults, and the governor's bold announcements yesterday will help us get there. Last but not least, I want to show you 3 other aspects of the master plan, just so you know. We're going to skip past our 23 strategies because it's a great panel. 3 other strategies, next slide, that are part of what we're doing. 1, data dashboard for aging. All the data we could possibly find about aging, we want to put in a single portal so we can measure how we're doing. Steve's work and others. If you go to the next slide, we're trying to measure affordable housing. We're working with our partners to say, how are we doing on affordable housing? And we want to go further as we do continuous improvement to measure all those different types of housing, so we can see that we're building not just the specialized housing for seniors, but all housing accommodates those different ages and stages, is accessible, is affordable, whether you're living alone, with your kids, with your partner, with your friend, with your caregiver, that there's an option for you in the market. Let's go ahead, one more slide, and then the next slide. Next slide. The second important piece of this is not just a state plan. We really know that California happens locally. And so we have 3 counties in California that have master plans for aging of their own, Los Angeles, San Diego, and San Francisco, but we have not been shy that our goal is that all 58 counties have some version of a master plan for aging. Many cities have joined AARP's Livable, Age-Friendly California initiative. And so we urge you to partner with local aging leaders, area agencies on aging, and other local leaders to think about, how does your local housing policy, what's your local planning commission doing? What are your local regional housing targets? How are they age-friendly, dementia-friendly, disability-friendly? Next slide. And just a little bit more in the local playbook. We really hope that is an actionable toolkit for you if you want to be the one who gets things going locally. And then last but not least, I have to answer what everyone always says, oh, great, another 10-year plan. How do we make sure it doesn't sit on the shelf? And the way we did that was we said, you know what, if we're going to achieve these goals in 10 years, there are specific actions we can take in the first 2 years to catalyze this happening. So the cabinet signed off on over 100 initiatives and put their name by the one they were going to do. And that's where we are right now, is beginning in January, we're implementing those initiatives. The governor proposed a budget investments in January. The new governor's budget comes out on Friday with more investments in aging and more across the spectrum to help us achieve all these goals. And there are many, many other initiatives that we are working on, particularly on standing up more of these supports and services so you can live at home in the community, advancing equity, and also addressing elder abuse, a very serious issue across many, many places. And we'll be forming very shortly an accountability committee to hold us accountable, to use that data from Steve and others' works to say, how are we doing? Are we on track? Where did we miss the mark? Let's improve and keep going. So we urge you to join us. This is where you can learn more. You can see the data dashboard, you can see the initiatives, you can see the local playbook, and you can sign up to join our not too frequent, but just enough to stay engaged. Together we engage listserv. So with that is a whirlwind tour of the master plan. I really look forward. I'm so excited to be talking about housing and housing is health and health is housing with you all. And now to be listening to this esteemed panel take us to the next place. Thank you so much.
Thank you, Director. So we are going to save our questions to the end, but we will take one hot question. Director, if you have a moment, we received a question from our friend Patty at Justice and Aging. She asked, when will the updated dashboard, the Elder Index and dashboard, be publicly available?
Well, it's publicly available now, and there are improvements happening all the time. I know one that's in the queue is we need better LGBTQ demographics, so that is in the queue. And Patty, I hope that's Patty Prunover from Justice and Aging, one of our terrific advocates and allies. Patty, if there's more that you're seeking, let us know, because that's a continuous improvement project. Thanks to West Health Foundation, thanks to UCLA, frankly, lots of great help with UCLA, and we're looking to continue to grow that all the time. So more soon.
Great. Thank you, Director, for this comprehensive overview of the Master Plan for Aging and for reminding us that housing is a common denominator between all of the MPA goals of health, equity and inclusion, caregiving, and economic security. So you've really set the stage for our discussion today. I would like to introduce our three panelists. First, Sarah Steenhausen is a Senior Policy Advisor for the SCAN Foundation, directing the Foundation's state policy engagement efforts. In this capacity, Sarah develops and oversees their state leadership strategy, providing technical assistance and educating state policymakers on issues impacting California's older adults, people with disabilities, and family caregivers. Before joining the SCAN Foundation team in 2009, Sarah was Assistant Secretary for Long-Term Care at the California Health and Human Services Agency, serving as the primary advisor on aging and long-term care, legislative and budgetary measures. Her policy career began in the California legislature as a consultant to the Senate Subcommittee on Aging and Long-Term Care. Sarah holds a Master of Science in Gerontology from the USC Davis School of Gerontology. Our next panelist is Christina Serrato, the Director of Operations for Episcopal Communities and Services Affordable Housing Portfolio. In this role, Christina oversees the management and resident services of affordable housing sites. The spectrum of services also includes Creative Living Plus, a wellness and life enrichment program for the residents. Christina oversees the nursing staff for the HUD-funded grant program IWISH at 6 partnering communities. She received her BA from UCLA and holds an MA in Politics, Economics, and Business from Claremont Graduate University. She is a certified property manager and holds a residential care for the elderly administrator certification from the California Department of Social Services. Our third panelist, Doug Shoemaker, serves as president of Mercy Housing California, the largest regional affiliate of Mercy Housing Incorporated. During the last several years, Mercy Housing California has expanded its pipeline dramatically and currently has over 4,000 homes in pre-development or construction. At the same time, Doug has moved the organization to strengthen its work with public housing and formerly homeless residents, particularly with individuals and families that are struggling with mental health, substance abuse, or multi-generational poverty. So we'll start with Sarah as our first panelist. Sarah, we have a lot of housers in attendance. Can you talk about long-term care in California? What is it? What does it mean to be dual eligible, a term that we throw around a lot? And why is it important for our older adults? Additionally, one of the issues that housers often encounter is that a senior can be considered very low income and qualify for affordable housing, but they may not be income eligible for Medi-Cal. So we call these individuals trapped in the gap or the missing middle. So what are some of these gaps in California's long-term care systems that these individuals face, and how does the Master Plan for Aging seek to fix them?
Great. Well, thank you so much, Megan. And it's such an honor to be invited to be here. I did put together a few slides to kind of provide the context for that, just to help connect where we are with the issues of health and housing and taking it a bit deep dive into some of the remarks that Kim made. So next slide, please. Before we begin, I know that many of you housers may not be familiar with the different terminology. So I just wanted to kind of provide a context for what we mean when we talk about long-term care, which is commonly referred to as long-term services and supports. A lot of times people don't make distinctions between what services they receive in a doctor's office versus what services they might need in other settings. The non-medical functional support is what we consider long-term care or long-term services and supports. These are services and supports that help people with their activities of daily living, like bathing, dressing, eating, walking, transferring, and mobility. Services that can be received in either a home setting, in a community setting, like an adult day healthcare center, in an assisted living setting, or in an institutional setting, like a nursing home. And these services are provided by paid and unpaid caregivers. But the important thing to recognize is that what people often don't realize as they age is that Medicare does not pay for these sorts of services, which brings up a lot of the challenges that we talk when we talk about housing and services and affordability. Next slide, please. Important aspect of thinking about who provides LTSS, it's often not realized that actually unpaid family caregivers represent the vast majority of our long-term care workforce. They provide about 2/3 of all care to people in their homes who are over the age of 65. So these are, daughters, partners, relatives, friends that just help people age in their homes or in their setting of choice. It is incumbent on us as a state to figure out how to support this population so that people can age in the setting of their choice. On the paid side of the continuum, there's a range of different paid caregivers. These are the personal care aides, the home health aides, the certified nursing assistants that work in institutional or hospital settings that provide services to assist people with their functional needs. But as the population ages, we really are facing a lot of challenges across the workforce. And it's estimated that we will need upwards of 600,000 more paid caregivers to meet the need. And on top of that, as Kim mentioned, we have a very diverse aging population. So we have to think about ways to ensure the care that's delivered is culturally competent and in the setting of a person's choice. Next slide, please. What's really important to think about when we think about our aging population is not only are people living longer, but as they live longer, they're acquiring disability and they're acquiring a need for long-term services and supports. So when you just think about the sheer numbers, when you compare numbers to 2012, which there were almost 550,000 people needing services and supports, by 2030, that number will nearly double. So this has a lot of implications, not only for workforce and financing, but also for housing. Because again, we need to think about where people receive these services and how we can have housing arrangements that provide services where people are and meet them where they are. Next slide, please. So I just wanted to provide a quick overview of the financing and service delivery system. As I mentioned, with long-term services and supports, people can't afford them. They don't realize that Medicare doesn't pay. And many of our middle income families end up exhausting their resources and getting onto Medi-Cal, which becomes the default payer. And this has tremendous implications, not only for our state and federal budgets, but also for how people age and where they receive their services and supports. Next slide, please. So when we talk about the term dual eligibles, again, this is a term that Megan mentioned, and oftentimes we don't know what it's in reference to. These are individuals who are older adults, people with disabilities, who are eligible for both Medicare, which is the federal health care insurance program for people age 65 and over, as well as people with disabilities, and Medi-Cal. Medi-Cal is the wraparound healthcare delivery system for older adults and people with disabilities that for what Medicare doesn't pay for, Medi-Cal can cover. And this is on certain things like prescription drugs, long-term care. What's important to note about Medi-Cal's coverage of long-term care is that under federal law, there's an entitlement to nursing home care under Medicaid law, but it's only optional for states to provide access to home and community-based services. This is really critical when we think about our service delivery system, because we know that people want to age in place. Most people want to remain at home and in the community. In fact, a recent poll came out that said that 88% of Americans prefer to receive services as they age in their homes and in their communities. And they expect government policy to play a role in helping them to do that. The challenge is Medicaid, federal Medicaid law, again, provides an entitlement to nursing home care and only optional coverage for home and community-based services. So this is a really critical issue and impacts how our state's delivery system is set up. And if you look at the next slide, you'll see that, as Megan mentioned, there's different terms. It's sometimes called the missing middle, the forgotten middle. But essentially, when we think about the programs that are there, like Medi-Cal, to help people who exhaust their resources and need to pay for long-term care, what it doesn't cover is the people who are middle income and don't have access to Medi-Cal to pay for their long-term care or to pay for the services and supports they need to stay at home. And in a study commissioned by the National Investment Center for Seniors Housing and Care, it found that 54% of middle-income Americans over age 75 don't have the resources they need. And that's considering both their income and home equity. When you take out home equity, 81% of people do not have sufficient resources to cover the cost of their care. So, a smaller percentage do have sufficient resources. That's 19% of the population that likely will never need to spend down their resources because they have sufficient. Next slide. So what's really important to consider is as Kim said, you all are aware, housing is not an island into itself. You have to consider the range of needs that people have. And if you don't have housing, but you have healthcare, you're lost. And if you have healthcare, but not housing, you're lost. And with that comes the whole range of services that people rely on, from health to LTSS to transportation and housing. But what you'll see in the next slide is that it's a very complicated maze. So this here represents a person in the middle who is surrounded by both the medical care delivery system and the social support and personal care delivery system, including some housing access programs. The challenge for people is that they don't live in silos and they don't think of themselves as silos. It's very complicated to navigate the fragmented system across different eligibility requirements, different funding streams, different administering entities. So really the ideal, if you look at the next slide, is a system where the person is really the center of the system and has access to the housing and the supports that they need to remain in the place that they call home. Next slide. So there has been multiple calls for change over the past 20, 30 years. Simply put, I would say the legislature and stakeholders have been fighting for something to address the needs of our aging population. And I would say today is different. Next slide. We see with the master plan for aging, as Kim outlined, a really comprehensive commitment to thoughtfully planning for the range of needs facing our population. I just want to call out a few important opportunities when we think about the intersection of health and housing. It sounds kind of bureaucratic when you talk about establishment of a new office at a state level, but the state really does play a critical role in providing the framework for how services are delivered. So as an example, within the Department of Healthcare Services, they have proposed establishing an Office of Medicare Innovation and Integration. This has the potential to really be provide leadership in testing new models of service delivery that look beyond just healthcare needs of our population, but also look at the range of social determinants, including housing, and how we can better connect not just the dual eligible population, but the Medicare only population with the housing and supports they need. So I know that we're going to hear about some of those successful models, and I just think that the master plan has the potential to provide the framework for this. We also see at the state level a commitment to redesigning and transforming our service delivery system through an initiative called CalAIM. And it's these sort of initiatives that are recognizing that you can't look at a person's health needs alone. You have to consider the range of other services and supports they need to when you think about successful aging. So next slide. Those are my comments. I thank you for the time and look forward to the discussion.
Great. Thank you, Sarah. That was a very comprehensive overview of California's long-term care and what it means to be an older adult, and particularly a low to middle income older adult in California, and what your options are in terms of long-term care. So let's turn to Christina Serrato. Christina, you oversee 6 IWISH sites. IWISH is HUD's Integrated Wellness and Supportive Housing Demonstration. Can you talk to us about IWISH and how it's helped participants? What does it mean practically on site? And what are some of the shortcomings and challenges that you've faced? And how do you see the long-term viability of IWISH?
Yes, absolutely. I see some participants who are very engaged with IWISH on this, this webinar. So I know I'm speaking to the choir a bit, but for those that don't know about IWISH, here's some information. So in 2017, the United States Department of Housing and Urban Development, or HUD, was appropriated $15 million from Congress to carry out a supportive services demonstration grant, which we called IWISH, which stands for the Integrated Wellness and Supportive Housing. It was a 3-year period, 2017 to 2020. In 2020, funding was appropriated for an additional 1-year extension with a 2-year drawdown. So that's where we are at right now. 40 affordable housing sites around the country were selected. California was one of only 7 states chosen to participate in the demonstration. All other states included Illinois, Maryland, Massachusetts, Michigan, New Jersey, and South Carolina. In California, 15 housing sites were chosen, and Episcopal Communities and Services, who I work for, is partnering in 6 of those grants with other providers. In this pilot program, it brings a full-time service coordinator, which we now call a resident wellness director, and a nurse to federally subsidize senior housing development. HUD created this opportunity for communities across the nation to gather data and show enhanced health improvements in affordable housing for seniors using the community as a platform. As we know, housing is health. And affordable housing communities provide a perfect venue to effectively address the needs of a vulnerable and high-risk older adult population who our residents are, and to validate the need for supportive services and health education among seniors. Specifically, IWISH seeks to produce evidence about the impact a supportive services model has in affordable housing, and does it impact and empower residents aging in place, their transitions to institutional care, and does it improve housing stability, residents' well-being, and improve their health outcomes and health care utilization? Is it reducing hospitalizations and emergency room visits? On site, the service coordinator and nurse work together with the participants to create an individualized plan to improve their health. This could include immunization promotion, monitoring the vital signs, reconciling medications, managing transitions with residents who return from a hospital or a nursing facility. It also could include helping them sign up for fall prevention classes, or working with them on weight loss, or getting signed up for mental health care. The nurses also supported and educated the residents while providing health inquiries that include blood pressure checks, weigh-ins, cholesterol screenings, sugar monitoring, and health education workshops. The nurses and service coordinators also made efforts to establish partnerships in the community. In one of our communities, they were able to establish a partnership with a pharmacy school to help residents get educated and manage their medication. The IWISH team worked as liaisons between hospitals and residents, and even made hospital visits a priority to ensure the residents know they are not alone. Although we won't have data analysis for a bit, the IWISH program is showing exceptional impacts in our communities. Some successes we have seen from IWISH and having a nurse and full-time RSC at the community include that we saw participants were engaging in seeing their doctor instead of going to the ER. Participants don't feel as scared of the health system. IWISH teams are preventing major health events through trust building and communication. And participants were getting better at regularly taking medication and also forming relationships with other residents. We saw a lot more isolation, especially in communities where there was many cultures. So we were pleased to see how participants are building communities across cultures through the education in the IWISH program, which reduces isolation, which was really important during this pandemic. The working relationships established by the IWISH team have been really a tremendous gift. We do see how they are improving the quality of life and well-being of all resident participants that we engage with, and we're just so hopeful that the program continues. Well, as you know, innovation is messy, and so there were definitely some shortcomings and challenges with IWISH. We learned a lot, especially just how management it works with a nurse. It's a new role for sites, and so how that team member fit in and just understanding their role. That was definitely a challenge in education. Also, IWISH uses HUD money, which is limited to pay for this on-site medical care IWISH team, rather than using Medicare and Medicaid, Medi-Cal, which covers anybody who qualifies. If HUD doesn't renew or extend this program after the money runs out, it will be difficult to find money for it in a private health market. Staffing was also a challenge. As we know, nurses are in high demand, and hospitals and health systems generally pay more than resident-based programs like IWISH. So in some communities, it was harder to staff than others. We did have some resignations along the way on the RSC and nurse side, and it has been a struggle for us to restaff those positions, especially when they know the funding is limited. Other challenges were language barriers. We do have communities where the majority of the residents speak a monolingual language other than English, such as Korean, for example. It was challenging to find nurses that could speak the language. And so we really had to work with our service coordinators, some who did speak the language, and use translation services to make that program successful. And because of this, it did create challenges for trust building among the residents with engaging with the IWISH program. A lot of times residents want to engage with nurses that look like them, share same cultural experiences. And so we really had to overcome that challenge. And then there were residents in general who just felt like because the program was, because it was including site staff, they feared, oh my gosh, management's going to find out about my personal business, and that's going to jeopardize my eligibility if they feel that I need to be in a nursing home. So again, just a lot of education about what this program was, HIPAA and all that. So it was a little bit of an uphill battle at times, but we overcame and we pushed through. As a result of all of this, there were a number of sites who really did focus on enrollment numbers and program participation numbers, more of a program mindset, just to overcome these barriers and trust building challenges, versus sites adopting the empowerment and self-determination goals of IWISH and the necessity of trust building, that motivational aspect of IWISH. Some sites did a really great job, but there were challenges just to get residents to participate and trust this new program. It is the goal and hope that the California Integrated Care at Home model will promote individual empowerment and collective community voice to achieve population-driven health system improvement. A few more is, although IWISH was really based on that supportive services at home model, HUD's goal with IWISH was really not about creating a population health system and seeking systems change. It was really about engaging and enhancing their resident service coordination program, getting a full-time resident service coordinator on site, which was great and needed, and sites did a really good job of enhancing their program. But it is our hope that the California Integrated Care at Home model can incorporate IWISH sites into a larger population health system. IWISH really was not set up to create sufficient volume within a geographic area to enable the kind of healthcare partnerships that are needed to improve the healthcare of residents. You know, they were spread out across the country, across the state. So although our IWISH staff are very powerful advocates for our residents, there wasn't going to be one single site that was going to change the way that LA healthcare system works and how and when discharges occur, or to the degree to which resident health goals are honored. And also, IWISH was organized as a national program. And so without that state level infrastructure, there are no resources to collaborate with state government, Medi-Cal or state programs. The state support is really needed for sustainability. You know, in conclusion, when we consider the long-term care landscape, we know it is a really complex system of addressing aging needs in today's really fast-paced, frequently shifting world. The future really is about how do we keep people home and the ability to help policy leaders move in that direction. We need systems change, we need a population health system, and we really need state support and dollars to do it. And that's what I have to share.
Thank you so much. So I know that we talked about maybe taking a question or two in between speakers, but just given our time, I think I'm going to hold off on some of the questions to the end and move forward with our panel. So turning to you, Doug, while IWISH showcased a partnership with the federal government, your work in San Francisco, integrating housing and services with the city and county of San Francisco, has been really groundbreaking. And I know you've learned a lot on the way. Can you tell us more about where you started with your Mission Creek project and kind of how your thinking and housing integration with healthcare has kind of evolved over time?
Sure, thanks Megan, and I appreciate going last because now Sarah and Christina have filled in so much of the story. So I guess I'll just start here, which is, like Christina said, Mercy senior housing communities, we have about 30 in California, all sort of operate with that backbone of a resident services coordinator. So the innovation of Mission Creek, which is now a 15-year-old property, it's about 140 senior apartments in the Mission Bay community of San Francisco, was a partnership in two ways. One with the Department of Public Health, which at the time was trying to downsize the large skilled nursing home here in San Francisco, Laguna Honda, and needed to find community-based alternatives for some of their residents. And also with an adult day health center called Stepping Stone, which we have multiple sites with. And so it sort of went in two different directions. I'll just say that the core of it, that's maybe where the most innovation occurred, was the Department of Public Health effectively pays for the rents of folks that were in nursing homes or needed institutional or were in institutional settings. But the idea was to try and find the community-based settings, as Sarah was referencing earlier, that they could live in, and we wanted to demonstrate that people could live independently with the right supports. And so between us and the Department of Public Health and Stepping Stone, that was really what the building does. And so there are a lot of those components that are sort of just basic to a senior housing community, at least the way Mercy Housing runs it, which is you've got a service coordinator, as Christina was referencing, that's sort of what we now sort of call the social determinants of health, figuring out everything from access to different programs, food security, social isolation, arts classes, just everything that kind of makes for a integrated life and deals particularly with some of those issues around isolation that we tend to underplay. And so those are big, and that's part of what that community does. There was also an adult day health center built into the building, and the hope was that many of the residents would actually access the adult day health center, particularly those coming out of Laguna Honda. Over time, it turns out that participation rate is really quite low. And it sort of led us to understand a couple of things about the challenge. One is it's very hard under today's circumstances to really have a senior housing community that has a preference for or requires that people who move in are the folks that really need the type of on-site services that an adult day health center would provide. Fortunately, in this case, Stepping Stone is a sort of a community-facing adult day. So while our residents or the residents of Mission Creek may not be the top users, there's lots of other people that use it. And that sort of gets to Christina's sort of population health piece. And in that sense, the adult day is just like having a health clinic on the ground floor. And I think there's a lot of partnerships that we do and others do where that ground floor public facing piece is an asset to residents and to the community at large, and really excellent. I think that the harder part maybe is trying to think through sort of what we're doing as a housing and health kind of integration to try and further that and enable us to replicate buildings like Mission Creek and other settings. And so I think that's really where the difficulty lies and where the work is in this master plan, and what we all, I think, need to dig into, to be honest. So a couple of things about it. I think, Sarah, you said very well, sort of the patient-centered world of healthcare meets the project-centered world of housing. And without any judgment in one direction or another, I think one of the challenges is if you think about operational efficiencies and some of the regulatory challenges associated with home and community-based service, particularly for things like unscheduled care, a senior that needs help in the middle of the night, their IHSS worker is unlikely to be there at 2 a.m. in the morning. And that's not a critique, it's just a fact of life. And so as we think about this, if you sort of start with, the vast majority of us in the affordable world do what might be called service-enriched housing, and that's sort of what I described as a baseline. And then you get anything from co-location with a clinic or an adult day to maybe enhanced services like what IWISH represents, where you've added a visiting nurse or something more clinical in nature to sort of add to the ability of seniors to live independently, particularly as their need for support, whether it's medical or non-medical health needs. And there's things we can do to add into buildings to do that. I think that as the seniors with more needs, we're trying to think about how do we approach what might be called like affordable assisted living, sort of that space between service-enriched housing and skilled nursing that unfortunately is a massive gap in this system. And so I think that's the part where I think, trying to turn off my little timer here. I was trying to keep myself to 5 minutes, which if you know me is a challenge. So I think that's the place where we really need to focus, which is sort of like, how does the healthcare world think about whether or not they want to make some accommodations to the housing model to adjust for a project-based approach in which some of the patient-centered aspects of this are challenging, and we may need some regulatory thought around, can we do clustered care? How do we do that without sort of upending the entire patient-centered world of home and community-based services, but in particular instances where we're trying to do something that is like an affordable assisted living context. How do we make that cost effective, and how do we not run afoul of some of the more complex regulatory issues like the Olmstead Act or the Olmstead decision and some of how that affects we do our work. So I'll stop there. There's more to say, but I think there's a lot of opportunity. I will just echo what was said earlier, which is for my colleagues out there in the affordable housing world, this is not something easily done at the project level. The integration we need is actually higher up the food chain. And I think programmatic level efforts are really important at this stage, as opposed to another round of pilots in which 5 years from now, we're still in pilot world.
Wow, thank you, Doug. So I've personally learned a lot. I feel like I work in this world, and I've learned a lot from hearing the three of you speak. So I hope that all of our participants today have also learned a lot. Some of the things that we've learned is that you can be a low-income older adult and still not qualify for Medi-Cal services that help seniors age in place, like IHSS. California doesn't really have an affordable assisted living model. So if you age out of independent living and can't afford in-home care, and you don't know how to navigate complex home and community-based services systems, you're likely headed to a skilled nursing facility. There are a tremendous amount of resources and home and community-based services out there, but they all have different eligibility criteria. And so Christina or Julie, do you mind sharing my slides? Thank you. So all of these home and community-based services and resources out there have different eligibility criteria. They have no centralized application system. How does an older adult navigate all of this? Promising housing and healthcare models are being demonstrated throughout the country, but various models struggle with the things we've heard today: full integration of care and services, or funding, scalability. So in developing the SITCH model, which is our California Integrated Care at Home model that Christina Green talked about earlier, we're proposing a population health system where a team of providers on-site at affordable housing supports a large number of participants in a flexible and cost-efficient manner. So I'll have you turn to the next slide. So this model creates a system of partnerships and communication networks that can collectively support thousands of elderly, as opposed to creating a separate partnership for each beneficiary. So we've looked at models from across the country, and many of the models we've seen have the same challenge, which is that they're not scalable. And this usually has to do with its funding mechanism. We've seen so many great partnerships in housing communities where a local health plan has a high number of plan participants. But if you move to the next zip code over, you may find a housing community that has over 20 health plans represented. And in that case, the health plans are going to be more reluctant to fund on-site services because they have fewer participants, and they're going to be, they're not going to see a huge return on their investment. So one model that we feel is a more sustainable funding model and tremendous outcomes to boot is the Vermont SASH program. And SASH is funded through a multi-payer waiver where Medicare, Medicaid, and private insurers all pay into a pool that is used to pay for the SASH model. And this makes sense because the cost savings from the improved health outcomes demonstrated by the model are seen by Medicare, Medicaid, and private insurers. So by having this multi-payer model, the contributions from each entity are really small, maximizing their return on investment. So we've taken SASH and adapted it to design SITCH for California. And so we're proposing a demonstration of SITCH in Los Angeles County to evaluate the effectiveness of this proposed model. So what this looks like practically is each housing site would be affordable housing site, would have an on-site care team consisting of an enhanced service coordinator and a community health worker, both working under the supervision of a master level RN coach. The on-site team would serve panels of 125 participants, consisting of both residents that are living in the affordable housing building, but also individuals living in the surrounding neighborhood. And the special thing about this model is that participants don't have to be dual eligible to qualify, only Medicare eligible, so that we can address that trapped in the gap or missing middle problem. The on-site team will coordinate with a core team of community providers representing social services, home health, mental health services, and the AAAs. They can also coordinate with primary care, PACE, hospitals, and nursing homes. So together, the on-site team and the core team provide comprehensive health and wellness assessments. They can provide individualized care plans, on-site one-on-one nurse coaching, care coordination, and health and wellness group programming. And, I like to say the beauty of this model is that it ramps up or scales back services and intervention as a person's health needs evolve. It also advances health equity by engaging people in their own health care. The model focuses on health education, access to primary care, and chronic disease management. Data tells us that Black and Latinx individuals are more likely to live in subsidized housing than white peers. They're more likely to have chronic illness such as hypertension and diabetes, and less likely to have access to preventative health care. And SITCH seeks to bridge these access gaps. It also seeks to disrupt the typical cycle of nursing home admissions by helping coordinate services that allow people to remain at home. And when someone does have to go to skilled nursing, the on-site care team is there to work with the person once they're discharged and help them transition back to home with the care and services they need at home. So based on the outcomes from SASH and other similar models, and I'll have you go to the next slide, we're hoping to see with our demonstration a reduced rate of growth in Medicare spending, reduced Medicaid spending among dual eligibles, a reduction in housing exits resulting from institutionalization, and improved health outcomes. So all of this said, SITCH is what we envision for California's future. It is a big picture goal, but it is going to take years to develop, to demonstrate, and to fund. And in the meantime, how do we start building community networks of health and supportive services for the residents living in your affordable housing buildings today? So let's turn back to our panel. And for the sake of time, I I'm going to ask you each to answer one question. So if you could try and keep it to a minute so we still have time to take some audience questions. What advice would you have for housers who are looking to create housing and health partnerships but don't know where to start? And so we'll start with you, Sarah.
I was like, darn, can I go last? So I can speak for everybody else. So that's a wonderful question, because I'm thinking the key is partnerships to start, because you have to, based on some of the really important concepts that you outlined in the integrated care at home model, you have to look for opportunities where there's financial alignment. So how can we best use the resources that are there and have the payer have some sort of incentive to want to invest in this model? So that means finding your local health plans. You need to consider who are the healthcare sector partners. So I would start with the Medi-Cal managed care plans in your local area, as well as the Medicare Advantage plans. And there are models at the federal level on special supplemental benefits for the chronically ill that allow health plans to provide limited support of long-term services and supports. So I would start there at the local level, but also at the same time, as Doug mentioned, the local government can be a very effective partner. I think it helped that San Francisco was driven by a mandate and a lawsuit to be able to provide access to services in the community through an Olmstead lawsuit earlier. But at the same time, we've seen local governments lead the way for these sorts of efforts. So those are my 2 cents. And in the meantime, we have to see the state ramp up its capacity to develop a systems approach.
Hey, Megan, do you mind if I just jump in after Sarah here? I think what Sarah said is exactly right. And I guess a couple thoughts. One is one of the challenges with the plans is their timelines. So very few of them actually have the ability to invest with you or commit to you for a very long period of time. So if you're developing something from scratch, they're probably not the place to start as a houser. They have 1 to 3 year timelines. They really are, they can want to do more, but that is not really the financial or legal position they're in relative to their contract with the state. Hospitals also challenged in terms of what Sarah just said, in terms of where the payer has the right incentives. So if I were starting from scratch, I would really start principally probably with my public health departments and think about them, because I think in general, they're sort of used to working with some of the same populations and can key in different ways. I don't think that's where it ends, but I think that's where I would start. And then I just want to note, I dropped into the chat a link to a report that Mercy Housing worked on with the Low Income Investment Fund. And I saw that Cecile Chalafour, who was at LIF at the time, is on and worked on this. But I think it kind of gives an outline of lots of different types of partnerships that would be involved, and what are some of the kind of system disconnects that you need to watch out for as you try to make these partnerships work.
All right, Christina Serrato. What is your advice for housers who are looking to create housing and health partnerships, and particularly with your focus on resident services? I think I saw a question in the chat around budget approvals and increases for service coordination. What would you recommend to housers for increasing their budget to fund support services?
Oh my goodness, I saw that. I'm like, wow, we're still trying to get HUD on the calls. Leading Age National is trying to get HUD on the calls so that we can really talk about like next step with this program. I mean, it's really about, that was another thing that I didn't mention, is that like working with HUD for them to understand this program and the importance of it. And we're still waiting. We got an extension for funding, but we're still waiting for our cooperative agreements to be re-signed and renewed, and for our funding to come in. And so I hear you. We need to have better communication with them, and we need to advocate on the importance of getting this funding and increases. We definitely need to do that. And I just really think that when you're engaging in this program, the service coordinator program, it's so important for owners and agents to really understand the components or requirements of operating the program, really understanding the regulatory requirements, to stay in compliance, and to obtain funding. And I understand that it's hard to get clarification all the time. And so we just really need to be in constant communication with HUD so that we really have clear expectations for the purpose of the program and how we can set up success metrics for the program and ensure staff is fulfilling the components of the program.
Great, thank you. So now I think we will invite Director McCoy-Wade back into our little group here, and we'll take some questions from the audience. See if she's still on the line. So we have a bunch of questions in here, so forgive me as I scroll through some of these. All right. Hello, Director. So, Director, we'll start with you. There is a question that says there are many home care agencies operating in California. Are cities or counties looking to partner with agencies to provide assistance and a comprehensive program for low-income members of our communities?
So I think the biggest opportunity in this space, and I will let others jump in as well, is what's happening with our Medicaid program and CalAIM. And I'm going to say, I'm still working on how to make this vision clearer and simpler because it involves the alignment of a lot of complicated pieces. But let me give it a go, and then everybody can jump in. So what we want to have happen is that Medicaid has the policy, and to Sarah's point, Medicare Advantage, to pay for that kind of home health aid. So we get the payer, right? The health plan then needs to have those agreements with the home health agency, which could be a private or a nonprofit or any collection and any other kind of broker to it. See, I'm already making it complicated. But what would happen in our vision is that the California vision is that the public could reach out and say, how do I find housing and health plan? And the health plan is able to access a range of county paid for services, health plan paid for services, community-based services, and wrap around in a coordinated way that person. So what the challenge is building all of those bridges so that it's care coordinated in a person center. But let's face it, the money has to follow, the data has to follow. It's a lot of system work as well. So let me just tell one side of the story that we're trying to work on from my department. Is the community-based side. We know that community-based organizations can be really important partners in delivering meals, behavioral health counseling, family respite. But if they're not connected to the health plan, that bridge can't be built. And we also know that for a lot of these smaller nonprofits, to connect with their systems is going to be really challenging. So one of the things we're really looking at, stay with me for one more second here, is how do we create these aging hubs, these networks, if you will, of aging and disability services, so that you'd have all of that kind of under one umbrella as a network. Independent organizations, for sure, but networked in a way so that a health plan could access all of them, so that APS provider could access, adult protective services could access all of them. So we are really thinking at the state about, right now, I'm sure it's like the airlines before hub and spoke, right? There was just a whole map of squiggles in every direction that health providers, housing providers, county providers, CBOs, and ultimately families are having to chase around. So how do we build networks of services that whether you're a health plan, a housing provider, adult protective services, or a family caregiver, you can tap into and be at that hub. So the governor's budget is trying to align both that policy on healthcare is allowed to pay for it, as well as the network connections, whether it's the public portal as a one-stop, the computer systems that connect us all together, and then that health plan, all those bridges. So again, I wish I had a simple picture to paint. I don't have the perfect metaphor yet, but it really is about taking all of our individual points and networking us in a way that, again, works for the person, but also for all these providers who are having to navigate way too many systems, way too many reporting systems, payment systems, grant systems. It's just not working for the ultimate customer or the critical service delivery.
Great, thank you. So Doug, I'm going to hand this question over to you because I feel like you've probably worked in this space a lot. So we have someone from a financial institution asking, what is the next step for bridging the gap between affordable housing, tax credit buildings, and nursing homes? So from a financial institution perspective, do you have any thoughts on that?
I can tell you what I think the gap is and what we're trying to do at Mercy. we're actually working right now with the city and county of San Francisco on some additional housing at Laguna Honda and trying to create an affordable assisted living piece along with independent living there. And so I think there's two things. One is the affordable housing finance system thinks in terms of 15 to 30 year timelines. And so it needs some certainty on whether it's a benefit versus an optional service or a longer term commitment than a 3 to 5 year managed care plan contract. And so I think one of the big challenges for DHCS is really trying to figure out, how to support AL assisted living like supports in affordable housing, which may mean creating some intentional programs to really kind of bridge those time issues and expectations around sort of who's being contracted with and how. And then of course, there's the opposite direction, which DHCS could go in, which is to really think about, does it want to loosen the cap or expand the number of assisted living slots in the state and really provide the right level of reimbursement for that to really induce not just people to be retained as board and care facilities, which is what I think it currently could do. But if it wants to drive expansion of assisted living, it's going to have to be a very different approach, which would mean, getting a rate that's up in the $5,000 to $6,000 range, probably, or maybe $4,000 to $5,000 range, and really thinking hard about whether that cap is going to be lifted or whether they're going to go even further and maybe just define affordable AL as a benefit under the system. I don't understand the cost implications of either, but that's the direction. We either have to sort of make it easier for the housers to sort of add the home and community-based services in a more comprehensive clustered home healthcare way, or we have to go the other direction and ask housers to sort of accommodate with our housing finance tools an AL model that might sort of graft onto our tax credit and other HUD financing, but in a way that sort of drives the operating and service costs of the model. So if I were in the finance world, I'd be saying to myself, I need to see the state move in one direction or another so that I can then work with a developer to know that they're going to be moving forward a project that's going to have a clear partner to work with from an ongoing finance or funding perspective.
Thank you. So we'll take one last audience question. And Sarah, this one is for you. Is California considering incentivizing payers and LTSS providers to collaborate financially in order to efficiently support population health from a geographic perspective, not a payer or condition slicing?
Yeah, that's a fantastic question. And I think this really aligns well with what the state is trying to do with this CalAIM initiative that Kim mentioned. It's California's effort to advance and innovate the Medicaid program. And this gets along the lines of trying to develop the fiscal incentives across the payers so that you can better connect people with the services they need. And in the area of older adults and people with disabilities, better aligning the Medicare and the Medi-Cal service delivery systems. And I think that that's where there's going to be opportunity to really expand access to person-centered services, social determinants of health with what people need, so that it's part of the healthcare delivery system. And as Kim said, this is part of reimagining health. It's thinking of health more broadly than just going to the doctor's office, but how can we expand those partnerships at the local level and develop the fiscal incentives? So I do think that really where the opportunity right now is with the CalAIM effort. And I know it's a little difficult because it seems far off, but I would engage in the near term with your local partners who are connected to the service delivery system and start figuring out what you can do to develop models that integrate well with the direction the state's headed. And Kim, you may have other things to add on to that as well.
Well, I mean, I think we've all wanted to see that true cost calculations of preventing falls, preventing hospitalizations, preventing nursing homes. And so we were hoping that the Data Dashboard of Aging, and again, building on the researchers' work, Steve Wallace and his colleagues, to be able to better capture, that some of the numbers that Doug was throwing out for assisted living, they might sound high at first, but compared to what is always the question. And so and also the highness of them tells you that people can't do it alone, that there does need to be a robust public role at the federal and state level, as well as a health plan role to make this work. So no, I just think that the part of it is doing a better job of answering the compared to what question rhetorically and with data.
Great, thank you. So we only have a couple minutes left. I wanted to briefly address, there were a number of comments in the chat that'll kind of summarize around older adults accessing housing and what are state and federal governments doing to increase the supply of affordable housing, particularly for older adults. I would just say that the state is working, they're trying to keep people housed. 2 years ago, they implemented a rent control measure. They've implemented an eviction moratorium during COVID to keep people housed. The governor has just announced over $12 billion to go toward housing supports and rental assistance. On the development side, we've been fighting really hard at the federal level through our national affiliate Leading Age to protect the 202 program, to expand it, to protect and expand project-based Section 8. To build more affordable housing, particularly for those that are extremely and very low income. So that said, I want to thank all of our panelists for sharing your work and your wisdom with us today. We've covered a lot of ground. We've talked a lot about the Master Plan for Aging and how it really touches all of the work that we do, whether it's housing, equity, caregiving, economic security. Housing is really interwoven into all of these things. We've learned about long-term care, its challenges, its new opportunities. We've talked about existing housing and healthcare models and heard advice about how we can better serve those living in our affordable housing communities. And finally, we talked about our big picture goal, which is California integrated care at home. And so again, thank you so much to our panelists, to our keynote speaker. I'm going to turn it back to Christina Green now to close us out.
Well, Megan, Director Wade, Sarah, Christina, and Doug, we cannot thank you enough for being here today and sharing all this knowledge and information with us. We are super incredibly grateful. I also want to thank my colleagues, Tim and Julie at the Ziman Center, and the support of all the Ziman Center's generous donors, without whom none of our work would be possible here today. I also want to finally thank my California Integrated Care at Home Working Group, Ayako Utsumi and Nancy Eldridge, and Megan, of course, in the group, for their continued inspiration and partnership. Now, if any of you in the audience want to engage with us on this topic, please don't hesitate to email me directly. Here's to a healthier California for all ages, where we as a community can come together to care for each other and create opportunities to thrive as we age, how and where we choose. Thanks, everyone. Have a wonderful afternoon.